Greetings. Thanks for tuning into this training. This is going to be relevant to you if you are a new or even existing provider delivering support through Ashland and or Bayfield County CCS programs. I'm Julie Winter, and I'm the Quality Control and Improvement Coordinator, a shared position across both counties. Hi, here I am. My role includes things like outreach to increase the number of people that we're serving, compliance with state statutes. So I'm the person on the other end gathering all of your documentation if you are a new provider, which is needed before you can start working with participants. I do trainings like this, process improvement, policy writing, all in an attempt to make things clearer and easier to understand for our providers and also our participants. I also have experience working as both a service facilitator and an individual skill development provider in both the Ashland and the Bayfield County programs. So that means that I have been the one providing that direct service and then writing my progress notes for the services that I provided, as well as the other end of that. So the service facilitator that was reading and reviewing and approving or giving feedback on progress notes, writing service plans, authorizing supports, working with providers that way. So experience kind of on both sides of what we're going to be talking through today. All right. Now, on that note, today's training is going to be significant, and I would really encourage you to feel free to pause the training at any time the recording, just to review anything in more detail, to read through the specifics of what I'm sharing on the screen, and use this as a resource. Continue to refer back to this training as you move forward with providing support. There is a lot to keep track of and to understand, and you're not going to get it all immediately. You're going to need to refer back to information. So my hope is that this will be one of those resources for you. Here's an overview of what we're going to be going through today during this training. All right, so to get started, if you've never heard of CCS, Comprehensive Community Services, let's start there. So CCS is a rehabilitative person-centered program, and it's meant to provide support relative to mental health and or substance use barriers. It is available to people of all ages. So we have youth and adults in our programs. It is also available in the majority of counties within our state, and 3 tribes currently have CCS programs. So there's a really good chance if you've come from or are going to another area of the state, there's probably a CCS program there. What makes CCS really special and different from a lot of other programs is that supports are meant to be provided in the community and or in the participant's home. This really does allow the person to maintain a level of an independence that just isn't possible with the next level up of care, which might be something like inpatient hospitalization. And the approach and that idea of, meeting people where they're at in the community and in their homes, that is meant to hopefully allow that those participants to get the support that they need to address their mental health and or substance use in the most independent kind of, place. So it's funded and paid for by the person's Medicaid insurance. Now, that's going to come back multiple times over because it does inform the way that we have to do things in our program because of that funding stream. So I'll be pointing out a lot of that. CCS is person-centered, and really that means that the participant is the one that determines, with of course our support, their services, and also they have complete control over their engagement or non-engagement in CCS. So we cannot require anyone to be part of CCS. That is something that they need to decide if they are eligible for entry. CCS is recovery focused, and really what that means is our program's goal is to graduate people out of our program. You know, the objective is to teach them the skills that they need to be as independent as is necessary for the goals that they set for themselves. And hopefully they'll be able to use what they learn in our program to eventually, utilize more natural supports or do things more independently. You know, that's the programmatic goal. And with that being said, on the other hand, there is no explicit timeline of how long someone can be engaged in our program, because it's completely based off of the individual and their progress, which of course is different for everybody. And by the way, recovery is not linear. We know that for sure. So things change all the time. This is just to say that there's no specific amount of time that someone can be in CCS, but they do need to be showing that they are, making progress. And again, that's not always a straight line. Our CCS programs in Ashland and Bayfield County operate on what's called a shared services model. And this just basically means that they are separate programs, and there are differences between, policies and procedures in each of the county programs, but we utilize shared supports. So I'm an example of a shared support. My work is for both of the counties. And there's a high likelihood, if you're watching this training, you may also be an example of a shared support that may be providing service in both counties. Now, as far as eligibility requirements and how somebody is able to enter the program, you can see these essentially 5 points on the screen is what needs to be met. The other thing that I like to say about this is you can think of CCS as kind of a prescription for that person's, mental health or substance use symptoms and diagnosis. So essentially, when we get the sign up from their primary care provider or their psychiatrist, it's that provider saying, they're essentially prescribing CCS for, that person. The level of need and impairment is something to note here, specifically if you are a therapist. So someone that's eligible for CCS has to require more than just outpatient psychotherapy. And really, it's in between kind of that level and kind of the highest level, inpatient hospitalization. So that middle is where CCS is appropriate. On the screen, you'll see the QR code, and you can go ahead and feel free to pause right now and scan that. That's going to take you to our online referral form, and that is just one of the ways that anyone can refer themselves or someone they know for CCS. There's more information there, and I'm actually going to pull it up on a future slide. We'll go through that a little bit. So when I'm talking to people about CCS, the first question that usually participants have is, well, what does that mean? What kind of supports can I get in CCS? And this slide is really taken from our brochure, which kind of lists out some of the possible supports available through CCS in a little bit more layman's terms. So the things in this light blue column really are examples of services that can be added to a service plan. They do not reflect, what is on every single person's service plan. Of course, that's based on the individual and most importantly, their level of need. I also show this because It's helpful to know as you are thinking about starting to provide CCS supports in this program that you are typically one of several members that are supporting the participant. So beyond your individual support, they may also be utilizing any of these others or something else that's not on this list because, of course, services are specific to that individual, what their goals are, what their needs are, all of those things. Some participants in our program have big teams, many people that are working with them because that is a choice that they have made. And other people have smaller teams. So they may only be working with, 2 or 3 providers through CCS. Again, totally based on what that person's needs are and what they choose to receive through our program. We're going to be going through the state's more kind of technical and clinical definitions of what these supports are in a little bit. This slide is really, if you are an independent therapist, it's going to be really notable to you, but helpful for anybody to know. So there are special billing requirements that are established for specific support. There are 2 types of supports that basically, if someone is utilizing these supports, they are required by Medicaid to be billed through CCS instead of that provider billing Medicaid directly. So this is the case if, for instance, someone is coming into the CCS program, but they already have an established therapist. Now, in those situations, basically, as soon as we know that they are established with a therapist that we are not currently contracted with, I would be the one reaching out to that therapist or agency to notify them and try to see if they are willing to contract with us. And that really is based on this requirement, which is that screenshot on the bottom of the slide here. And this is taken from Forward Health, which is the entity that oversees the Medicaid reimbursements. You can see here that, if someone is in the CCS program, then outpatient psychotherapy and also adult mental health day treatment are required to be reimbursed through CCS. Sometimes the therapist is unwilling or unable to contract with us, and that is a decision that they can make. If the therapist cannot contract with CCS, then unfortunately it does require the person to essentially choose between either maintaining their therapist and not being in CCS or admitting to CCS, and then we would help them establish a new therapist. So similarly, if a person is, engaging with day treatment, those providers are also required to be credentialed through CCS, which again, on the back end just means a switch in their billing. I also want to note if someone is in CCS, a participant is in CCS, and they identify that they want to start working with, a new provider to deliver service, and we do not have an established contract with that provider, a therapy provider, or any other provider, we would need to establish that contract first before that support can be authorized. As you can see here on the screenshot again, there, with the exception of therapy and day treatment supports, all other supports, if they are covered under other benefits for that person, can be reimbursed separately and provided outside of CCS. So for instance, someone can receive peer support in our program or substance use counseling or medication management, but they do not have to receive it through us. So they could receive that kind of support, outside of CCS. We would obviously want to know that that's happening so that we absolutely do not duplicate those services, but that is absolutely, a possibility. Okay, so we're going to get into how to essentially like write your notes and enter those into our electronic health record. But before we do that, you really need to have an understanding of how your support is established, once someone is in CCS. So we're going to be going over these steps and kind of the process that we utilize for identifying and then authorizing and then providing those supports to a participant. Okay, it always starts with the exact same steps. So step one is the participant is working with the service facilitator to identify what their goals are. And this usually happens through what's called a service plan meeting. And the service facilitator is asking, what do you want to achieve? And they are looking for that person's direct quotes. What is it that the person, regardless of what we think, what does the person want to achieve? So on the bottom of the screen, you'll see there's a participant goal and barriers here. This is an actual example. It's just been redacted. So this person, you can see, said when asked, they want to be able to manage their depression, hopefully be in a better place. I'll have my own vehicle and not be watched all the time. And then on their service plan, the service facilitator would have specified that what that quote meant is the participant will live in her own home and be reunited with her family and will have stable mental health symptoms. Okay, so that was the goal that the person identified. The next thing immediately that the service facilitator would ask is, great, if that's what you want to achieve, what's getting in the way of you doing that already? Like outside of CCS, why can't you do that? And that is where we are trying to capture, the service facilitator is trying to capture the barriers, because the barriers, quite honestly, are what really inform what kinds of supports can be provided through CCS. So what's getting in the way for this person is the symptoms of her depression. So they're a barrier to her completing the necessary steps to obtain her own home. There's obviously a bunch that like falls under that umbrella, right? Like necessary steps for obtaining your own home. There's a million necessary steps. So, depression is kind of, the symptoms of depression are the main reason, she can't complete those. Now, on that note, another thing that is asked once those barriers are identified is there anyone already available outside of CCS that is helping you or could help you? So based on the DHS 36 administrative code, which dictates, CCS and what can and cannot be done, 36 does specify that natural supports need to be explored first before we can staff anything through CCS. So in this situation, like if this person's mom, was super supportive and they said, yeah, my mom like really helps me to keep on track. She helps me with all my paperwork and scheduling appointments. Like that's an example of something that we could not then staff through CCS. But if there aren't natural supports like, family member or friend, or if they're not engaged in other, community or agency supports that are helping them, that is where then we are identifying what is appropriate to staff through CCS. So, when those things are identified, where there's not already a support that's helping with those barriers, that's where the service facilitator is saying, hey, I'm hearing you say this. These are some of the types of things that we could help you with through CCS. And here are some of the providers that can deliver that support. So this step is why we actually need a biography of all of our providers who are delivering services, because it allows the service facilitator to provide that person with some choice surrounding their supports and who delivers them, which that is also actually written into administrative code that they do need to have choice. A couple things to note here. So service facilitators are the only ones who can add or adjust supports for the participant. So if you are aware of a need identified by the participant that you're working with, just make sure to encourage them to share it with their service facilitator, or you could even mention it explicitly in a progress note that you're writing, like this came up during our meeting. And that will give a heads up to the service facilitator to, circle back with the participant to address that. Okay, so we just talked about, how that goals and the barriers and the needs and the supports are identified. So now, once it's identified that the participant does want to move forward with adding something to their service plan, the service facilitator then writes that support into the service plan and has to tie it to the goal with the language that they are using. So essentially, writing and finalizing the service plan is what authorizes and generates those supports to be sent to you as the person filling them. So you can see, on the bottom here, again, we saw that participant's goal, we saw the barriers that were, getting in the way of achieving that goal. On the right-hand column, the support added to the service plan, about halfway down, you're looking at description details. So if you are a provider who is receiving this, which you would get in an email from the service facilitator, when you first get this, you're probably going to be scanning quickly to that description details, because this language that's included here is telling you exactly what you can do, what is inside of the scope of your support. And again, because there are sometimes many people working with the participant, we do emphasize, the importance of staying inside of that scope so that we're not accidentally duplicating any services that are being provided by other CCS, providers, or even natural supports, which, could be a reason why something is flagged from Medicaid. Service facilitators, when they are sending those authorizations, are always going to be offering to the participant, actually, before they even send that, when they're talking about the sports, they're always going to be offering to the participant that they will do a side-by-side introduction with the participant and the person who fills the support. So there's a really good chance when you get that email saying, here's the new authorization for you to fill, that the service facilitator might be also trying to coordinate with you a meeting time. The only reason why that might not happen is based on participant choice. So, the service facilitator will always offer it, but, the participant is the one who says yes or no. So, maybe the participant already knows that provider, or they're working with them for a different support, and this is an additional one. So those are examples of why, maybe that side-by-side meeting, they would choose not to utilize. If a vendor employs multiple providers, so if you are part of an agency and there are other people working in CCS, when you get the authorization, it's not going to have your specific name included in the description details. And just a note on this, the service facilitator has a list of all of the providers that are available and what kinds of supports they can offer. They're going to be going through that with participants, but it is up to the agency's supervisor. So again, if you work for an agency, it's up to your supervisor when that authorization comes in to determine who is going to fill that. The service facilitator is obviously going to be conveying, I think so-and-so would be a great fit, but of course your supervisor is going to know if that person has bandwidth to fill it. Okay, so the authorization has been sent, it has been filled, you have started working with the participant. Now, what has to happen is basically we need documentation of the services being delivered. So progress notes are going to be written and entered into our electronic health record as the documentation showing that the services were provided. And the time for what you spend with that person and associated with that person's support is broken down into two different buckets, kind of. And these are established basically by Medicaid. So Medicaid has determined what type of time they will pay for and what, unfortunately, they will not pay for. So on the, billable time column, basically all the time here is reimbursable. So the time associated with, your actual meeting, how much time it took you to meet with the participant for that authorized service that you are providing, the travel time associated with you getting there and back, and the time it took you to write your note after that meeting was done. So all of that time is considered billable and will be reimbursed. And if you are employed, with an agency, they're going to be invoicing, us, the CCS program, for the time that you spent. Now, in the right-hand column, the necessary but non-billable time, unfortunately, the reality is what that billable time includes is not all inclusive of the time it actually takes to, deliver really great service. And there is time that is going to be required, but unfortunately, again, Medicaid has determined they will not reimburse for it. So examples are basically any time where you're coordinating about the participant, but they are not with you. So if you are coordinating with the service facilitator and the participant isn't with you, it's not you sitting side by side with the participant and doing a call to the service facilitator, right? Like that would be billable, but if they are not with you, then it is non-billable. Communication with the participant that's not face-to-face or telehealth is tied to your support. So examples would be like reminder calls or texts or things like that. And unfortunately, no-show appointments and all the associated travel time and documentation surrounding that no-show appointment. The reality is that the participants that are in our program are in it for a reason. They need help. And no-show appointments are a reality. What I can say about this billable versus non-billable time is, we recognize that you will incur non-billable time. And how we try to address that is during the rate setting process with agencies, before we even contract with a new agency, I am working with those agency contacts to essentially determine what the rate is that the county will pay for the services that their providers deliver. So part of that is breaking out all of the costs associated with delivering service through CCS. And part of those costs is the non-billable time, because it's required. You have to do some of this stuff. So basically, we put an estimate of all of that non-billable time and the billable time, and our rate setting tool essentially calculates an hourly rate that we will pay to the provider agency that should be just a little higher to account for that non-billable time. So, just so that we try to address that, and we do recognize that, it is something that, that non-billable time is required. The other thing on this is that when we are first rate setting, we can only use our best estimates. So after a while of providing service, every year when that provider or that agency's contract comes up for renewal, we can go back and look at what the actual non-bill time was and billable time, and use those figures to update that rate. To do that, we need documentation. So notes have to be entered for us to know what that data is. So it is advantageous for you to, of course, be entering your billable time notes, which is required, but also, try to get in those non-billable notes. It helps us understand what's happening with the person, but also it helps to capture data for you or your agency. Now, there are some exceptions to when you can be reimbursed or essentially enter a billable note for something that is outside of your authorized support. So some of those exceptions are if you're unable to work on your authorized support due to the participant being in crisis. So like you show up to work on, for instance, maybe you're working with them on, filling out a housing application, but when you show up, they are suicidal. Obviously, that is a crisis situation and it needs to be addressed. We are not expecting that you leave because they're not in a place to, fill out that application. So what you would be doing is spending your time instead to help them connect to that next level of crisis intervention supports or services, like doing a call to, Northland Counseling Crisis Bed or the crisis line, or, things like that, or connecting them with natural supports that can help them. So the reason why this is an exception is because when you enter your note, the support that you are going to be tying your service to is going to say that you're authorized to do housing support, but the content of your note is going to show that you didn't. So this is an example of where you are going to be making a notation that the reason why you didn't is because of this accepted, situation, the crisis situation. And that's an example of where, the content in your note doesn't line up with your authorized service, but it's still billable. If you're attending a service plan meeting, which, by the way, participants have total choice over who can attend and engage in their service plan meetings. And that includes you as another support provider. It does not have to be just the person and their service facilitator. So if they want you at their service plan meeting, you probably should reference that was discussed. And then when you attend that service plan meeting and go to write your note, again, the content of your note is not going to reflect that you're working on, securing housing. It's going to reflect that you were engaged in the service plan meeting. So when you enter it, the service facilitator would have provided a different option for you to select, which is called recovery planning. And that's the one that you select when you're entering a note about attending a service plan meeting. I'm going to show you that once we get into the electronic health record. If you provide backup supports for a coworker while they're out, then that's another example of an exception, because you're going to be billing under their authorized support. So you may not be, typically working with this person, but if your coworker is out and then you fill in for them, you're going to be using their authorization and writing your note under theirs. And then, of course, you're going to be making explicit notation to the fact that you are providing the support as backup for so-and-so, because they're out on vacation or something. All right, the last kind of step is just the continual assessment of the person's need and how they're engaging with those services. So the service facilitator's role really is kind of that oversight of, how services are being provided and how the participant is engaging with them. So how they're doing that is they are reading all 100% of the progress notes that are written. And by policy, they have to be reviewing every 2 business days. And that reading through all those notes, approving them, allows them to kind of gauge how things are going. It also really allows them to identify if, new needs are popping up, or, things need to be changed that they can address with the participant. So that's called continuity of care, and that's a piece that the service facilitators are doing. Participants do complete service plan meetings and comprehensive assessment reviews with their service facilitators at least every 6 months. That's minimum. In reality, actually, changes happen for some people more frequently than that. So they could be having amended plans at any time. They don't need to wait for that 6-month mark to change something. So anytime a support changes, the plan needs to be amended. And that happens frequently because, quite honestly, recovery is not linear and things change all the time. If someone is no-showing for you habitually, it's really important for you to be identifying that and again, putting in that no-show note because while the service facilitators are reviewing what's happening, that gives them a little heads up that, hey, something's happening here. We do have a no-show policy I'll go into a little bit later. Just wanted to make another notation also that the service facilitators are the ones kind of, again, facilitating services, but they are overseen by mental health professionals. So each of the programs has a mental health professional, and that is someone, who is really doing that clinical oversight. So they are looking at and reviewing all of the documentation that the service facilitators are developing. So they're also verifying another level of that medical necessity. Participants do have to actively engage in services with the CCS support at least every 90 days, and this should be support that is working on a specific thing with them, like that housing or something like that. So they do have to have that engagement at least every 90 days. This is in the DHS 36 Administrative Code. And the reason is that really less than that could indicate that essentially there's a lack of medical necessity, and that could require an administrative discharge from the program. The reason why your non-bill notes for no-shows is really helpful is because it helps that service facilitator keep on top of that, because they do need to notify that person or attempt to notify them. They're given reminders at the 30-day, 60-day, and 75-day of no contact that they will be administratively discharged if they're not engaging, which again, there could be all kinds of reasons why they're not engaging. Maybe it's a good reason. Maybe, they're more independent, or, a less exciting reason, right? Like maybe they're super symptomatic. We have people that, are administratively discharged or choose to discharge from the program, and they can come back into the program at any time if they remain eligible. They do have to reapply and go through that process, but it's not uncommon, for someone to discharge and then maybe they come back in. Okay, so talking about medical necessity and client choice surrounding, why things change, basically, if a support authorization is changed, it's increased, it's decreased, it's rewritten, it's ended, any of those things, it means that probably the reason is one of these bullet points, so or multiple. So things change a lot in our program, and we try really hard to be adaptable and make sure that the documentation associated with the supports that people are getting is up to date. So, take a minute to pause and just read through this list to be aware and familiar of, why something might be changing. I also want to point out a really happy and wonderful reason why support might be decreased or ended, which really, this is our programmatic goal. This is the goal of CCS, that, maybe somebody's support is ended because the participant's ability to meet that need is starting to be more independent, or maybe they have a natural support that has improved their ability to meet that need. So that's cause for celebration, and that's our hope for all supports, really, that are authorized. Okay, so take a minute to pause this training, go back and review anything on those previous slides that might be helpful to dig into. The next piece that we're going to get into is the more clinical and state definitions of the types of supports that are provided and how that relates to your role and your scope. All right, I want to start here with the service facilitator, because the service facilitator, which everybody in our program has a service facilitator, the service facilitator's role really is all of these, highlighted words. So they are coordinating, they are monitoring, and they are assessing the authorized supports that are provided to the individual. So what you're seeing on the screen here, this screenshot, is actually the definition of service facilitation in CCS from Medicaid. And any support that is authorized through CCS is part of a list that's available on the Forward Health online handbook, which again is essentially Forward Health is facilitating the payments for Medicaid. So this is saying, what they believe a service facilitator, role and support is and what it needs to fall inside of. So think about the service facilitator again as being that person who's trying to monitor the big picture. So they're not only authorizing individual supports based on needs and choice and things that arise, but they're also trying to look at how are all these individual supports working together to help someone progress toward their overall goal. And again, that's why, you may be one of many people. Maybe something is happening for you with that person that is different than what that person is doing with another person or provider. So the service facilitator really is the one that is assessing that and using that information to make sure that the supports that are provided are effective. Okay. The next one I want to go through is actually the most common type of support that we authorize through our Ashland and Bayfield County CCS programs, even more so than psychotherapy or substance abuse counseling or some of those others that are, you would assume. So individual skill development and enhancement. This is side-by-side support for teaching someone how to gain skills they need that relate to their goal. So you can see, once again, the state's definition of what this service is here. And you can see things like, problem solving, training, decision making, modeling, mentoring, cueing. So when I was providing individual skill development, I always kind of boiled down my role and thought about my role as really a teacher. So my job was to teach someone how to do, fill in the blank. And this is the support that on that, slide a while back when I was showing what kinds of things happen and are authorized through CCS, this one is utilized in a million different ways. So, this could be like individual skill development for securing housing. It could be individual skill development for, organization of appointments or developing coping skills to, combat isolation. Like it can be so many different things. And that's why it's the most prevalent support that we authorize. This support, based on the requirements of DHS 36 and Medicaid, so this type of support can be provided by any role authorized in CCS. So on your initial training log, you need to select which DHS 36 definition aligns with your role. And individual skill development can be provided by any one of those roles. Here's an example of how this support is actually authorized. So once again, on the left, under the state's definition, that's really the clinical definition. And on the right, this is an example of what an authorization looks like and how that service facilitator has written the support to align with what that state's definition is, but also to be specific to the individual. So this is actually the same authorization that we already saw, which was that support for independent housing. Now, also of note, One of the things that you need to provide as part of the initial documentation before you start working with people is a copy of your job description. The reason why we ask for that is, number one, it's a requirement that you understand, based on DHS 36, how your role aligns with the services that you are authorized to provide, essentially this definition up here. So that's why we ask for that. Another support that we authorize on plans is called peer support. And if you're not familiar with peer support, peer specialists are people with lived experience with mental health and or substance use, and they're in their own recovery. So they also go through a rigorous certification process, and their supports, you can see here, there's some overlap with that individual skill development, but really the difference I kind of think of with that versus peer support is the person delivering it. So the person delivering it is, a person in recovery. So they are, their role is to help with promoting the participants' wellness, help them with, self-direction, their recovery process, helping them kind of navigate systems. The goal, I like how they put in here, it's a mutually empowering relationship. So they're working as equals toward, the objective of, living in recovery. Now, something to note here, like I said, peer specialists go through a certification process. So if you are a peer specialist, then you qualify under the role that is defined in DHS 3610-20. So that's the one that you would be selecting on your initial training log. And if you are not a peer specialist, you cannot be authorized to provide peer support through CCS. Here's an example of what a peer support authorization might look like. So go ahead and take a second to pause the slide and read through that. There is a lot of information in there, actually. So you can see the way that this was written is a little bit more broad than how that individual skill development support was written, which really was specific to, gaining a specific skill or, achieving something specific. Whereas the peer support, once again, this is a little bit more broad because it's about, working toward recovery. And, service facilitators will write things differently and based on, of course, that individual. So what is it that this person needed related to, achieving recovery? So those things are listed in here, and you can see the person filling this authorization would have a fair amount of bandwidth on what, they can do with that participant. Individual or family psychoeducation is another, support that we authorize. And this is kind of special because it's different or a little bit more flexible than some other supports in that it can be provided to the individual. And you can see this is really problem solving, educating, helping someone to understand and address their kind of, symptoms and kind of how to, work toward understanding how those present. So you can see that here, and it can be authorized with an individual, but most often the way that we add this to service plans is as family psychoeducation. And an example is, for instance, when we have youth in the program, we can authorize, like the child is the participant that is enrolled in CCS, but on the child service plan, we can put family psychoeducation on there so the provider can go into that home and really work super closely with, for instance, mom or dad to help that parent understand what is happening with that child a lot of times it boils down to behaviors. Like, how do I address this behavior in a healthy way? Like, what are interventions I can use? Those types of things. So that's a really common way that we authorize it. Not the only way that we do, but commonly that's how we can do it. Now, you'll see here that anyone that qualifies under the role and qualifications options in 36 is eligible to fill the support. So there is a potential that you could get an authorization for individual or family psychoeducation. And just so that you know and can be thinking about how is this different from, for instance, individual skill development and enhancement, right? Like individual skill development and enhancement is about those daily living skills. Like, what is it that needs to be achieved to kind of work forward? Whereas this psychoeducation is really about how to address, the pieces relevant to, for instance, symptoms of the diagnosis. Here's an example of how this has been authorized in the past. Again, this example shows it was an authorization with a therapist, but it would not need to be authorized with a therapist. So in this situation, the therapist was able, because of this type of authorization, to meet with the person's family members. And you can see here, the objective was, to work on family dynamics, systems of change within the home, to aid behavior interventions, mood stabilizations for the participant, age-appropriate interventions that can be put into place within the home. So those, again, this was for a child, and that's a really common way that we authorize this. Okay, and then we also have psychotherapy. So obviously, psychotherapy, this is a trained and licensed individual, master's level at least, that is able to support someone with modifying and identifying, behaviors, characteristics, things like that, and that relate to diagnosis and treatment. So therapy can be provided individually or in a group setting. We really only authorize group therapy if it's with a DHS 35 clinic. And as I said, to deliver psychotherapy through CCS, you have to have a level of qualification aligned with, being able to provide that. So these are the most common providers that we see coming through for authorizations or that we're contracting with to deliver psychotherapy. So if you are a psychotherapist, there's a good chance when you are selecting which role you are defined under, it's probably going to be one of these. Here's an example of how a psychotherapy authorization might look. Again, relating back to the state's definition and, the reason for meeting, tying to, some of those barriers. This is an example of how we authorized the psychotherapy support for a group that was happening. So once again, only possible with DHS 35 clinics, but just as an example, that's how that is done. Okay, so we've talked a lot about services that can be provided under CCS and what that looks like, but Medicaid also is really explicit about what cannot be delivered through CCS. And there's a comprehensive list on the Forward Health Online Handbook. I've got some of them on this screen, but it's not all of them. So a couple of these that I want to go down through is that top one. So services that are not rehabilitative. This is essential, and it is something that we come back to all the time because it's emphasized so strongly from Medicaid. CCS is a rehabilitative program. So this is why we need to be demonstrating through progress notes and assessments and service plans and all of those things that we are trying to assess and monitor the person's progress. And this is also why when staff or providers are delivering services, they must be delivered side by side with that person or directly with that person. If you are authorized to deliver individual skill development or even any of those other ones, you cannot teach someone how to gain those skills without being with them. So that is why we will not reimburse for your time, and Medicaid won't reimburse for your time if you are not working directly with the person. So nothing about me without me. Please make sure that you are always keeping that in mind. If we find that someone is really, they've had support for a long time, they are just not making progress, they are not showing signs of working toward independence, that can indicate that maybe the rehabilitative aspect or type of program that CCS isn't appropriate for that person. It could indicate that maybe they need to be discharged from CCS and referred to a different program that's something like long-term supports, where the support providers could actually do things on their behalf instead of trying to teach them how to do those things independently. Okay, another thing on here, which is included, is they make a special note that services that are not rehabilitative, including that are primarily recreation oriented. This is another one that we have to really look at closely because of what we authorize in our program. So you saw on that master list I showed you of some of the types of supports that we provide, there were things on there under individual skill development that were like things like yoga and CrossFit and arts and crafts and mindfulness and meditation and community integration and socialization. There's a myriad of things that can be authorized. Those types of supports might look recreation-based. However, the reason why we can authorize them, and essentially why their medical insurance is willing to pay for them under our program, is because we are validating that there is a medical necessity. It's not just that they want to do CrossFit, it's that learning how to do CrossFit allows them to gain coping skills that they can use independently to kind of address, like when their symptoms are increasing or things like that. So that is the difference, and it is a requirement that we are conveying, especially through our notes, that medical necessity. I'm going to go through the next section, which is how to actually write your note and what content needs to be in there, and there's a lot of emphasis placed on that because of this. Because if we are not showing rehabilitation, the note that is submitted for payment from Medicaid could be declined because they're not seeing that this person medically needs that service. So it's really important, and that's why we are making efforts all the time to show the progress that is being made or increase of need and things like that. Okay, another one on here is crisis intervention. So you can see one of the things that is not covered through CCS is crisis intervention. However, coordination for obtaining those crisis intervention services is covered. So what this means is, first of all, people in our program are in it for a reason. It is not all that uncommon, unfortunately, for our participants to need crisis intervention services like Northland Counseling Crisis Bed, accessing the crisis line, inpatient stays at Tamarack VHU. Those are all considered crisis intervention services. And CCS's role is not to actually provide that crisis intervention. It's to connect that person with that next level of care. This means that your billable time, if you are coordinating crisis intervention services, like that example that I mentioned a while ago, your billable time ends when that person has a plan for safety that could include the formal crisis intervention services that I just listed off, or maybe informal crisis intervention services. For instance, if they have a safety plan and one of the things that will keep them safe is having their partner home with them. Like that can be something that demonstrates their need has been met. Of course, this is completely based on the situation and all of those factors. But the main thing here is if the note shows that you are trying to be that crisis intervention, that is something that we cannot pay for. If the note shows that you are working to connect them with the crisis intervention, that is billable. Time spent solely to transport members. So basically, we cannot be transporting anyone if it's just for the purpose of getting them from point A to point B. It's very clear. Now, this is one of the things that relates to a difference in policies between the Ashland and the Bayfield County program. I'll go into this a little bit more in our travel policy, but essentially, if you are providing a service at the same time as you are riding with that person in your vehicle, that is something that can be covered and you can do through the Bayfield County program, but is not possible through the Ashland County program. So keep that in mind that there is that difference. I'll get into it a little bit more with our travel policy. You're also seeing here services that can't be provided while someone is in the hospital. So basically, CCS services essentially are paused if someone has a hospital stay or they go inpatient, and they can only resume, really the service facilitator support only resumes if it's related to facilitating that person back into the community. So keep that in mind if you're working with somebody and they have a hospital stay, your supports are going to be paused while they're in there. On that note and related is that medically managed inpatient treatment services. So this means that basically services cannot be duplicated if something is being provided in the hospital setting. So an example is like if they have a social worker, that's facilitating their coordination of care and discharge from the hospital. If that is being provided through the hospital, we cannot duplicate that. So just a special note there. There are also, of course, other things on this list that are on this slide and beyond that. So go ahead and pause to kind of navigate to that online handbook if you're interested in learning more. Okay, the next section we're going to get into is how to actually write your progress note. So we have specific requirements of what must be included in a progress note for us to approve it and basically pass it through to Medicaid for the reimbursement. I just want to preface this by saying our standards are significant. And it will take you a little while, unless you're a therapist who's been writing these types of clinical notes for a while, it's going to take you a while to get the hang of this. There are lots of supports, resources, and information that we've developed to help you. So please utilize them. All right, so getting started, what has to be included in your progress note and why? So what you're seeing on this screen in the table is essentially a rubric. We have a progress note rubric that outlines the different sections that have to be completed for a billable note. So you have an assessment and activity section, a reaction and response section, a plan section, an other section, and a life area section. Those sections are what you need to complete if you are entering a billable note. There are some differences between billable and non-billable notes, which I'll show you in a little bit, but let's start on billable notes first. So to preface this, CCS is a Medicaid-funded program. So the services must be considered clinically and medically appropriate to provide them and for us to be reimbursed for them. Because of that funding stream, that dictates all of this content that is needed to be included in every single billable note. Since services are provided to individuals by various staff, requiring staff to include observations of how the person is presenting in each note ensures that we can track their ongoing level and quality of functioning, which is a requirement of Medicaid and DHS 36, and I'm going to get into that specifically. Doing this also helps us identify when interventions or increases or decreases in supports might be appropriate based on changes in how the person is presenting. And basically, those could be linked to changes or increases or decreases in their symptoms or stability. Some providers ask their participants to actually rate some of these things, so they're getting the information directly verbatim from that person, and that can be a great way to assess someone's level and quality of functioning. Okay, so that assessment and activity section, you can see here what must be in this section to pass grade is, number one, the reason for meeting. So you are going to be referencing what you're working on, which is tied to your authorization. That can easily be said in one line. So like, met with Joe Schmo to work on a housing application. There you go. That meets it if your authorization is relevant to housing support. You also need to include at least 2 observations, not opinions, observations of how the person presented and maybe the place of your meeting if it's relevant. So you can see that we have 4 options here. You need to choose which of those 2 are most relevant to touch on in your note. The reaction and response, so what is needed is reference to progress that's been made or lost during your time working with them. So if they say something like, wow, I feel like I got so much done, or maybe they don't even say that, but you can reference it by, we completed the application today. Like, that is progress made, okay? Also, you need to identify how the person responded to at least one of these bullet points, and you choose what makes sense to touch on based on what happened during your meeting. The plan is really like what happens next after your meeting concludes. So you have to include, if you know it, the specific information about your next appointment with them. So when are you meeting with them again? And what are you going to be working on during that appointment? So meeting again on Wednesday next week to continue researching available apartments. There you go. That meets that. If you know it, you also need to describe what the person is planning to do or complete prior to that. So, of course, that whatever's relevant to their mental health or substance use progress, right? So maybe they are going to a local recovery event or something like that, or maybe they have a service plan meeting that's coming up. Like, those are things that you would want to include there because it allows us to monitor progress. The other section is usually left blank, but there are 2 reasons why you might put something in there. Number one, if you showed up to work with a person and you could not work on your authorized support because of a crisis that was happening. So I gave you one of those examples already. You would make note in the other section, unable to work on housing authorized support due to Joe Schmo being in crisis. Use time instead to, connect to the crisis bed. And then the rest of your sections will be filled out about what you did related to connecting him to that support. Another reason why you might put something in the other section is if you need to give additional context about what you are billing. And an example might be like, if you always meet with Joe Schmo and it takes you, 3 miles and 15 minutes for travel, and then all of a sudden the note that you enter, your travel is an hour. well, the service facilitator is going to say, is this a mistake? So you need to include some context, just a short, sweet note about why. So an example might be, you could enter into the other section, long travel due to poor weather. And that's enough information. You don't need to go into huge specifics, just enough to, kind of give that context. The last section is life areas, and you're going to be presented with a list of options that you choose and select from. So you need to select at least one of these, and they should be relevant to probably your authorization and also anything that was kind of addressed and relevant to the support and meeting that you completed. So you need to check at least one. Oftentimes, there will be more than one checked. Okay, so I mentioned that the reason for, the specificity of all of this is really tied to the requirements of billing through Medicaid and also DHS 36. So what I'm showing you, this screenshot that I just put up here, is actually an excerpt from Forward Health. And again, Forward Health is the entity that oversees the Medicaid payments. So this is what they're saying about the information that has to be included in a progress note. And this is them telling us if it doesn't include this, then it doesn't meet the requirements for reimbursing. So in this, you can see they are identifying that the note must include data relative to accomplishment of treatment goals in measurable terms. Now, this is why I said and emphasized observations, not opinions. So observations are things that you actually saw, the person actually said, you actually completed, you can actually assess, not just what you think happened or what you think is the case. So you need to back it up with some evidence, okay? This is also why we need to reference the progress that is made or lost during the time with them. And one thing that I always emphasize people to think about is the term nothing about me without me. So thinking about, again, that rehabilitation, the progress, right? So you are tasked with teaching someone skills that hopefully they'll be able to utilize, independently and to, relate to their progress. So you should never be doing something for that person without them. It might be easy for you to just drop off their application at Section 8 on your way back to the office. But by you doing that without them, you are not allowing them to learn how that interaction happens. So really super important to always be thinking about that. The progress notes must also document significant events that are related to the person's treatment plan. So this is why, if you showed up and they were in crisis, that is required to put into a note. And actually, there's a special timeline for getting that note in. You have to get it in within that day, basically. So this is also why, if there are other things that they are doing that's relevant to their mental health or substance use recovery, we want to know about that. So if they say that they went to a recovery event at the perk, or they're going to, that's relevant because, it shows kind of their engagement in that related to their recovery. Also, they are specifying assessments that contribute to an overall understanding of the person's ongoing level and quality of functioning. Okay, this assessment section is usually the hardest for people to wrap their head around because, it feels like you're making a judgment call. But really, what we want you to do is really assess these pieces because of the reasons that I mentioned when this slide first came up. So if there is a change in how they're presenting or their mood or, something like that, that oftentimes is an indicator that something is going on, either an increase or a decrease in their symptoms or their need. So that's why these are required. And clearly, it's not just us that is wanting it. You know, this is a requirement of Medicaid. So what I was just showing you is from Medicaid. Now, this screenshot is actually from DHS 36, again, the administrative code that dictates, you know, how CCS operates, is funded, you know, what not is funded, how CCS operates and what can be delivered through CCS. So you can see here that CCS service delivery information, progress notes, need to include the person's response to the services and the changes in condition. So again, changes in condition, response, this is directly where we're pulling it from and why we're requiring it. Changes in services that are provided. So this is why, you know, if you are going to continue working on your authorized support with them, why it needs to be documented. This is also where those life areas selections tie to. You can see here, right in 36, it is identified that observations of changes in activity level or in physical, cognitive, or emotional status. Okay, so very clearly linked to the reason why we are asking for that in notes. And when we are getting that assessment from everybody providing service to the person, it allows us to really assess that big picture of how things are going with that person. Reports to treatment or other activities from outside resources that may be influential in the CCS's service planning. So we don't need you to tell us every single little tiny thing. It's the things that relate to their mental health and substance use recovery, because that can relate to the services that are authorized. So if they, you know, have something coming up that could be, you know, indicate like an increase in need or symptoms, you know, like that is notable. You got to be thinking about all of those things, and that really, you know, those are why we require the information in our progress notes that I've just gone through. For providers that are used to delivering clinical services like therapists, this is, you know, just really a review because you're doing this anyway. But for providers who are not used to writing clinical notes, this can be kind of jarring. And I hope that explaining the reasons why maybe is helpful in understanding and just wrapping your head around like what's included. Okay, so the next thing that we're going to do is I've told you what has to be included in a note. And now what we're going to do is we're going to watch a little scene here. If I have any Seinfeld fans, we're going to watch this scene. We're going to imagine that I am authorized to provide the support that's over here on the left to George. Now, we're imagining I am in the scene because I'm, you know, authorized to provide that service to George. And then after the clip, I'll show you how I would write my note for delivering the service. So once again, the service that I'm authorized to provide is I'm going to support George with learning skills needed to obtain independent housing. Support is to include thought processing and side-by-side utilization of healthy coping skills to avoid isolating and lack of follow-through in response to depression and anxiety symptoms.
Every decision I've ever made in my entire life has been wrong. My life is the complete opposite of everything I want it to be. Every instinct I have in every aspect of life, be it something to wear, something to eat, it's all been wrong.
Tuna on toast, coleslaw, cup of coffee.
Yeah. No, wait a minute. I always have tuna on toast. Nothing's ever worked out for me with tuna on toast. I want the complete opposite of tuna on toast. Chicken salad on rye. Untoasted, with a side of potato salad, and a cup of tea.
Well, there's
There's no telling what can happen from this.
You know, chicken salad's not the opposite of tuna. Salmon's the opposite of tuna, because salmon swim against the current, and the tuna swim with it.
Good for the tuna.
George, you know that woman just looked at you.
So what? What am I supposed to do?
Go talk to her.
Elaine, bald men with no jobs and no money who live with their parents don't approach strange women.
Well, here's your chance to try the opposite. Instead of tuna salad and being intimidated by women, chicken salad and going right up to them.
Yeah, I should do the opposite. I should.
If every instinct you have is wrong, then the opposite would have to be right.
Yes, I will do the opposite. I used to sit here and do nothing and regret it for the rest of the day. So now I will do the opposite, and I will do something. Excuse me, I couldn't help but notice that you were looking in my direction.
Oh, yes, I was. You just ordered the same exact lunch as me.
My name is George. I'm unemployed and I live with my parents.
I'm Victoria. Hi.
Okay, so now what I'm going to do is I'm imagining that I was in that scene to provide this support, and I'm going to walk through how I would write my note for that support. And I'm going to have to use some creativity here, so stick along with me. All right, so the assessment and activity section, again, the first section that you complete, I would note, this writer met George at Monk's Cafe per his request and as planned previously to encourage him against isolating. All right, so reason for meeting, what you're working on tied to your authorization. So you can see I'm referring back to language from my authorization and I'm putting that right into my note. George was there with his two close friends, Jerry and another CCS participant, when writer arrived. Okay, so that is a description of the surroundings. I'm mentioning that he's there with friends, and that is notable because, again, part of why we're probably meeting at the cafe is to help him avoid isolating. Also, just something I want to note on this line, I mentioned Jerry and another CCS participant. That is indicating that Elaine is in the program, and I can list it this way in my note because I'm not disclosing Elaine as the participant, or I could say Jerry and Elaine. What I cannot say is Jerry and Elaine, who is another participant in the program, because that would be a breach of HIPAA because I'm sharing Elaine's medical information. He was dressed in clean and seasonally appropriate clothes. Okay, that is me identifying and assessing his physical appearance. He presented with good hygiene, but appeared not to be clean shaven, as is typical for him. So this one made sense to mention because it sounds like something was out of normal for him. So he wasn't clean shaven, but he usually is. So that is notable because it can be an indication of how he's doing, mental health wise. George presented as discouraged at the beginning of this appointment, as evidenced by use of satirical humor and ambivalence about his inability to meet his goal. Okay, so this is me describing the observation, not opinion, of his demeanor. And one of the tricks that I always used when I was delivering services and writing notes is if I was including an observation, how I took that from my opinion to an observation is that I would include evidence. So I'm saying the reason why I think he was discouraged, which would be an opinion, I think he was discouraged, it's now an observation because I can cite that he used satirical humor, he had ambivalence about an inability to meet his goal. So that's the evidence that takes it from an opinion to an observation. However, his mood and demeanor improved after an interaction with another customer whom he engaged in conversation as a result of Jerry's encouragement, as evidenced by smiling, upbeat tone in his own statements. So Jerry really was the one that was like prompting him to kind of engage, and that could be something that we mentioned in the next one. But this really is kind of the assessment section. Now, what you can see here is I'm an overachiever. I addressed not only point one, the reason for meeting, but I also addressed more than just 2 observations. I addressed all 4. Just to be clear, I would not have had to address all 4. I could have done, the demeanor and the hygiene. That I could have just chosen to do just those 2 or 2 other ones, whatever I felt was relevant. It's totally fine if you are detail oriented and you want to give all that context. It helps a service facilitator or anybody else reading that note to understand more about the situation. But to meet requirements, I would have only had to have addressed 2 of these. All right. I do get the question when I do this training, do I have to write in 3rd person? And the answer is no, you can definitely just write in 1st person. That's totally fine. Here's the reaction and response. Now, this is not a requirement, but typically we see this section as the bulkiest section of a note. All right, so my response is, George reported, every decision I've ever made in my entire life has been wrong. My life is the complete opposite of everything I wanted it to be. He went on to convey his disappointment about still not having secured independent housing or a job and stressed that he believes this because his decision-making intuition is always wrong. Okay, so that is a great example of using quotes. Whenever possible, try to use the person's direct quotes because it came directly from them. There's no kind of interpretation needed usually, that's them conveying, that's firsthand, right, an observation. So whenever possible, if there are good quotes that relate to their mental health or substance use, make sure to include those because then you don't need to cite other evidence. They are saying it verbatim. This is also a really good example of referencing what George is conveying, his lost progresses. So that is like a great snippet. Upon self-reflection of this, he decided to switch his regular food order, which is very out of character for George. This decision appeared to result in a sense of accomplishment for opting unprompted to do this, as evidenced by his tone of voice raising and the order being provided with more conviction than is typical. Okay, so I felt like this information kind of falls into the other factors that arose that relate to his progress, because obviously this decision was really, something that had an impact on the way the rest of that meeting went. So this is notable to include. George's friend noticed a female customer across from our table who appeared to notice him. The friend and Jerry encouraged George to continue doing the opposite of what his intuition and response would usually be by approaching the woman. This is actually an example of prompts that his friends gave. So that's why I included it, but they're not prompts that I gave. So if I would have given them, that would have checked that off. Though out of character for George, he was convinced by their reasoning and introduced himself to the woman, who appeared receptive to him based on smiling and openly engaging. Okay, interactions with other people. Clearly, that was something notable. George was overheard sharing self-deprecating announcements about living with his parents and being unemployed, but appeared surprised when these comments did not result in the woman ending the conversation. This was evidenced by him smiling and making eye contact back with his writer and his friends. All right, so obviously that's where the clip shuts off. I'm using my imagination for how I would have wrapped this back into and relating to my support. George exchanged contact information with the woman and returned back to this writer and his friends with a very improved mood, as evidenced by excited tone and statements such as, "I can't believe that just happened." Okay, successes, for sure. That's an example of success and really progress, right? This writer and George's friends congratulated him and facilitated his thought processing and reflection. Notice I'm using language from my authorized support about his improved outlook and self-confidence he was displaying as a result of taking a risk he would normally avoid. Again, referencing progress made. George agreed and stated he was going to keep trying to do the opposite, to make more connections moving forward. This writer noted the same approach could be applied to the housing application he had opted against completing during last week's meeting with this writer. George agreed. So that is, kind of, again, referencing back to the support and showing he agreed with that. So that may indicate kind of a change in focus or emphasis or interest in, kind of working toward that. The plan section, again, this is what happens after we finish that meeting. So George plans to call the woman from the restaurant this week in hopes that they will meet up for a date. He will also finish filling out the housing application that he had begun last week with this writer and will submit it before the next appointment with this writer on Tuesday, September 15th at 1 p.m. Okay, so that is describing what the participant plans to complete prior to our next meeting without me, and the specific information about when our next meeting is happening and what we're going to focus on, which is coming up. So we'll meet at the Vaughan Library to print off additional housing applications and then go for a walk while reviewing his progress and making a plan for next steps of follow through related to his housing search, and goal of submitting at least 2 applications by the end of September. George also mentioned he is meeting with his service facilitator, Betty White, right before his appointment with this writer next week to begin work on his annual service plan. So that's, again, more information that I know that is relevant to his services. And when his service facilitator reads this note, she's going to be like, oh, good, it's on his radar. All right. The other section was left blank because there were no, things that happened that were relevant to that. And then for life areas, again, checking one or more that apply, I thought, life satisfaction, definitely. When he arrived to the appointment, he was indicating poor life satisfaction. Social network and family involvement, obviously that interaction with the woman at the restaurant and the fact that he was with friends. Community living skills. So we met in the restaurant probably, to help him avoid isolating. So that's part of getting out into the community. Housing issues was mentioned. He mentioned that, and I addressed it. And then, of course, mental health was related. And he did mention that he is unemployed. So I marked employment. Okay, I also get the question with this, like, what's an example of a crisis situation that would be listed in the other section? I've referenced this in previous slides, but this is an example of, like, if you showed up and the person was in crisis, like this paragraph might be what you write into the other section, and then the rest of your sections, you just describe what you did with that time. So feel free to pause the recording right now and read through that. All right. Now, the meeting that I was just describing, that I wrote my note for, was in person, but you may end up providing services to participants via telehealth. So, and that's just fine as long as you can deliver the same level of service through telehealth meeting as you would if meeting in person. So just want to note that there are some specifics around this. So if you are, switching, let's say the weather is horrible that day and you are supposed to be meeting with a person to help them complete a form, like you could probably do that with them via telehealth and it would be just fine to switch to that format. But there are a couple things you have to keep in mind. To meet via telehealth, you have to be using a HIPAA compliant connection, and FaceTime is not a HIPAA compliant connection, and the regular Zoom is not a HIPAA compliant connection. So if you are employed with an agency, you should, definitely talk to your supervisor to figure out what connection you're utilizing. We talked about it has to be you have to be able to provide the same service. So the example that I gave you, is functionally equivalent, but maybe you are authorized to work with somebody on integrating into the community, which means like getting out and engaging in an event or something. Obviously, if that is your authorization, that is not something that you can do functionally equivalent via telehealth. So it is dependent on what your authorization is. Also, a participant cannot be required to receive services via telehealth. This is in DHS 36. So it is their choice whether, they do want to pivot into or authorize, services via telehealth. So obviously, telehealth typically includes, video and audio. Whenever possible, we want that to be the method that you utilize. But the definition of telehealth does indicate that it can include real-time interactive audio-only communication, so a phone call. Again, it needs to be functionally equivalent, but what it doesn't include is communication between the provider and the member that consists solely of an email, a text, or a fax transmission. So, that's why thinking about like a reminder call is not going to be billable. If you connect with that person for the call and you address something related to your authorization, it would. If you leave a voicemail, that is not telehealth. Progress note content. So the only kind of difference between the requirements of writing your billable note if you delivered the service via telehealth versus in person is that in your assessment and activity section, if you are meeting via telehealth, one of those 4 areas that you need to address, you have to address 2. So one of them has to be referencing the description of surroundings. Basically, this allows us to comply with the confidentiality and HIPAA requirements if it's in your notes. So you would be referencing the telehealth meeting format and any notable things about the surroundings or, very importantly, people that are present. So an example might be George and I met via telehealth. He was alert and engaged throughout. That is, a description of his demeanor and attention, right? So that's one of those 2 assessments. And then the second one would be he was at his mother's home. She did not participate, but was present in the room with him. So that would be the second. So that would meet my assessment, those 2 things. I would also need to reference, what was the purpose for meeting. Relevant policies and documents. So we have a master plan and policies document that has like all of the policies related to CCS, and inside of that are some things that you need to review as a new provider. So you do need to review the telehealth policy. I'm going to show you where to find that at the end of this training. And you also need to sign a telehealth provider agreement. You can indicate on that if you are open to and willing to deliver telehealth or if you are declining to deliver. But either way, it does need to be signed and submitted. Okay, also, I mentioned that there are differences between the requirements for billable notes versus non-billable notes. And you can see the requirements for billable notes are pretty significant. You'll get the hang of it, I promise. But non-billable notes do have a different set of requirements. Basically, non-billable notes, because Medicaid doesn't reimburse for them, we do not submit those onto Medicaid like we would for a billable note. They are, however, kept as part of that person's official medical record. So because they're in the person's medical record, they still need to comply with confidentiality around, HIPAA and all of those things. But they don't rise to the level of the billable note requirements. Also, as I mentioned previously, our no-show policy states that, like with non-bill notes, meaning no-shows, in order to enact a change in a service based on no-shows, like let's say somebody continually habitually no-shows with you, we are not expecting you to nonstop just keep on showing up. In our no-show policy, it does state after a process has been followed, that support can be ended because of that. But if we are enforcing a consequence, like ending a support based on them not engaging, we have to have documentation of them not engaging. If you don't write non-billable notes for all the times they stood you up, then it's as if it never happened, and we can't enforce that consequence. So once again, another reason why non-bill notes are really helpful for us and important. On this screen, you'll see this table, which the billable notes column, this is basically a concise version of those rubric expectations that I just went through. But the non-billable notes, you can see essentially they're more streamlined. You don't have to meet every single one of those individual checkoffs on the rubric. You don't need to select like area selections, all of those things. Now, I'm going to show you some actual examples of billable versus non-billable notes in our electronic health record in the next section. So go ahead and pause at this point if you need to go back and look at anything that was reviewed in this section, because we are going to be going on next to how you are going to gain access to and navigate ECHO, which is our electronic health record, and how progress notes are entered through ECHO. Okay, so to get started, gaining ECHO access is done by essentially you need to meet the requirements of getting all of your training done, your initial training for CCS, and all of the required documentation that needs to be submitted to us. So I'm the one on the other end that verifies all of that is completed. And once that is all completed, that is when I convey this person is cleared, they're credentialed, and they can start working with participants. So at that point, I would, send that along, and then you would be waiting for an email with the information about logging into ECHO, ECHO Vantage. And something to note is that if you are a provider working in both programs, then there are two separate logins. So the Ashland County one you can see up here, the naming convention for your username, and then the Bayfield County one, again, a different site. You can see that this is a little bit different for the username because it includes that Bay on the end of it. So the email that you get with access from Nettie Tittle is going to include your initial password to get in, and then once you're in, you're going to need to update it. All right, I'm going to give a little bit of an overview here of what ECHO looks like, and then I'm going to be switching to the actual ECHO site so we can see it in real time, and I'll be opening up notes and showing you, how to enter those and then how to get your notes approved and finalize them. So to begin with, here is the ECHO homepage, essentially. This is the Vantage Point page, and you can see here a big section is the scheduler. We actually don't use the schedules, so it's always going to be blank. You will have a list of clients over here that you're authorized to work with, so you can select those to get into their contact information. And the messages and alerts, so this is going to be really important because the way that your notes are approved is by you getting a message in ECHO from the service facilitator telling you that the note that you wrote is approved to sign, i.e. finalized. So you are going to be in the messages a lot, and you should be checking these pretty consistently. Unfortunately, ECHO does not have a notification system to just notify you when you get a message in ECHO, so you will need to be logging in actively and looking at that. The other thing I want to say about the messages is that this these messages are specific only to the communication you have with service facilitators about your notes. So there should be no content in these messages that is client specific. If it's client specific, it should be in the note. It shouldn't be in the message back and forth saying, this is approved to sign, or here's an error, please fix this. The other thing I want to say about this is that at any time, a participant has the ability to request a copy of their medical record. So that means that they could, in theory, get a printout of all of the notes that were written for services provided to them. So that is another reason why you always want to be keeping everything, as far as observations, not opinions, and, just keeping that in mind that they could be reading these at any point. There is a clients tab that is also where you could search for clients or participants, and when you open that up, that will give you their contact information. So when you first get an authorization, this is the way that you would know where that person lives. If you get an authorization for working with somebody and you go into Echo and try to find their contact info, but nothing's coming up when you type them in, it just means that probably a selection was missed on the back end. So what you want to do is just email the service facilitator, or maybe the mental health professional, but start with service facilitator, and they'll probably be able to just make that correction. Okay, so I had mentioned the messages feature. Now this is a little bit more specific view of that. So here's an example of when you open up those messages. This is an example of a service provider, so a direct support provider's inbox. So you can see these are service facilitators that are linked to the participants that this person is working with. And check out the information that is being shared here. So it's brief. It's just about the notes being approved to sign or corrections needed. It's only about that content. And then this screenshot is the other end. So the service facilitator inbox. So this is what they're getting from the direct support providers that are writing those notes. So oh, I changed that time, so things like that back and forth. Okay. And then there's also the services tab. Now this is probably where you're going to be more often when you are inside of Echo. This is, you are going to be seeing all of the notes that you write, but also notes that other team members have written about participants that you're authorized to work with. So you can see theirs, they can see yours. Quite honestly, you're probably not going to spend much, if any, time reviewing anybody else's notes but yours. So just know that, you are going to have access to that. This is the page where when you're ready to write a new note, this is how you do it. So you click on the new service button, that little plus button in the bottom right. Now, what I'm going to do is I'm going to switch over to the site and I'm going to walk through the Echo site. Okay, so let me get in there. Now, just as a note, I am actually in a test site. The only real difference is that there's not real participants loaded in this one, so that's why I'm using it. And there's an orange bar instead of a blue one that you'll see. Okay, so this is me logging into Echo, and I'm landing on the Vantage Point page again initially. Now, just to go over what we had reviewed, on the clients page, if I type in my client, that will bring up the contact information and anyone else that maybe, is approved to coordinate with about that person. The services page, once again, is where you go to find the notes that you have written. And this is definitely where you're going to be most often. So in here, a couple things. To start a brand new note, you are clicking on the bottom right, New Service. And this is where you get to this initial page, which is kind of the service detail page. And this is the specifics about the type of support, the day that you delivered the support, all of that stuff. You fill that in first, and then you're going to be clicking on Progress Note. That's where you enter in the content. I'm going to be showing you that in another example here. Before we go into that, though, I do want to just show you on this long list of notes and services, there are a couple of things to be aware of. You can tell which of these notes are non-bill because they have the CCS NB versus what's billable. So CCS ISD, so individual skill development. If it were peer support, it would indicate that acronym. So that is how you can tell the difference between what is non-billable versus billable. I also want to go through these icons here. So there is the signed progress note is the green check. Now, this means that the note, you wrote it, you were given approval to sign it by the service facilitator, and you have signed it. So this note is finalized, it's done. Basically, when you log in to figure out if you have to sign any notes, you don't have to worry about these green ones because they're already done. So let's go in and just look at some of these. You can see the information that's included here, which I'm going to be going through in more detail on another one. And then I'm going to open the progress note. So you can see this one is signed, and this is an example of a non-bill note. So it's just like a call to somebody, a reminder call. And as I mentioned with the requirements, the non-bill note, I just put all of my info in that one box, which is just fine. Go ahead and pause the recording if you want to read through that. Here's an example of a billable note. So this is a billable note for the service to George. And I'm going to just open this up to show you kind of this difference. So here's what I read through when we were looking at that. And you can see this one has been signed. Okay, so that is how you know it's been signed and it's done. You don't have to worry about it. Now, there's also unsigned. So the unsigned notes are going to have this yellow icon. And these are notes that you have already written. So you've already entered in all of the details. You can see I could adjust these because it's not signed, it's not finalized, so I can still make edits. And I wrote all of the information in it, but I'm waiting for the service facilitator to give me approval to sign it. So you can go ahead and pause the recording if you'd like to read through this note. This is an example of supporting somebody with learning how to utilize public transportation. Here's the plan associated with that. And relevant life areas. Okay, so once again, because it hasn't been signed, it has been saved, which I typed the note and then I pressed save. So because it hasn't been signed, which you do not do until you get explicit approval in an echo message from the service facilitator, because it hasn't been signed, this can still be edited. After it is signed, it is locked for editing. All right, so I'm going to show you how to actually submit a note. And I'm going to do that through this one, which you can see here, it has the alert that it's missing the progress note. So this means the content, the description of what was done is not in that note. And that can happen certainly if you like open up Echo, you start, writing your note and then you get pulled away. Like that could be an example of why. Okay, let's go down through what you select on these pages, this page, the service detail page. Now, there is a resource that I just want to point out. When you are first starting to write your notes, you are going to want this note entry and monitoring process resource. This tells you exactly what information and selections you need to make on that page. And it's going to be very helpful for you, especially when you're first starting to write notes. Okay, so let's go through them. Obviously, this is the date when the service was provided. The duration time is the total time associated with that service, billable or non-billable. So the total time associated with what was done. The client obviously put them in. You are the staff member. You do not need to select a supervisor, so do not make a selection there. The program is always going to be community support services, county community support services. Just to note that the counties use ECHO for more than just CCS. So there is a chance by the time you are reviewing this recording, there may be additional selections on these drop downs that are not even showing right now. So that's why it's really important to be referencing what exactly you need to select on these sections from that resource. Okay, the POS, place of service, is where and how that service was delivered. So because we met at Monk's Cafe, that was in the community. There are selections here that don't relate at all to what you would be able to provide. So make sure you're making correct selections. Community, office, which would be if you're meeting in your office, telehealth, audio only, or telehealth, in home or in community. Those are some of the most common ones. So again, that is how you select and identify if it was a telehealth appointment. This one again was in community. The activity is linked to what service you are authorized to provide. So I was authorized to provide individual skill development and enhancement. So that's what I need to make sure I'm selecting. You will see all of these other options on there. So it's really important that you make sure you're selecting the one that ties to your authorization. If you accidentally make an incorrect selection, that's an example of why the service facilitator will come back and say, you need to make this correction to your note before it can be finalized. You're also going to notice on here that there are selections that don't even relate to CCS. So just make sure that you are being careful about what you select there. The attendance is always going to be service completed, regardless of whether your note is billable or non-billable. This will always be completed, service completed. Where you are identifying if it is a billable versus non-billable note is in this section. And even though this doesn't have a little orange asterisk, this is a required section for you to complete. So obviously the George service was in person, so that's billable. Telehealth, you should not be completing because remember, if you delivered your support via telehealth, it would be identified on your place of service option. So this one just leaves blank. The diagnosis is going to be pre-filled for you to select. Okay, so now I would be able, you can see this is blue, so this means I can go ahead and click that to open up the section where I'm actually putting in my content. So now what I'm going to be doing here, I'm going to go into a lot more detail in a minute about how to divide out your time, which is kind of tricky. But to begin, when you start writing your note, you have to complete that service detail page, and then you get to this. My suggestion is once you get to this, that you just start writing your note because you need to figure out how much time it takes you to document. So go ahead and do that first. Service plan, you are always going to be selecting the most recent service plan, but never the final plan. The goal is going to be what was on the service plan, which I showed you an example of that. So you'll have that to select from the dropdown. and your support. So that would typically be here. Again, that's the authorization that, like I've shown you a whole bunch of those. Okay, so now I'm going to get into just typing my content in. So I've got a document here that I'm going to grab this from. While I'm doing this, when I open up this note, I'm trying to keep in mind how long this is taking me. You're just going to kind of monitor that in your head. Like, how long is it taking you to type this up? And just for reference, this note, this George note, is actually a really detailed note. Your notes, you know, again, as long as they meet the requirements for the rubric, they do not need to be this detailed. Okay, so now I've got all that in. The next thing I would typically do is put in my mileage and the to and from. So the to was CCS office, Ashland to Monk Cafe. And the from, if I didn't have another appointment directly after that, it would have been Monk's Cafe to CCS office. Okay, and then the travel time associated with that. So the lowest that you can put in for travel time and direct service time is in 15-minute increments. So the lowest would be 15. Even if it took me 5 minutes to drive there and back, I have to round it to the nearest 15. So I know that. And now I am done with my documentation. So I now finally have all the information that I need to be able to write this note. And I know that I spent 13 minutes writing my note. The documentation cell is the only one that is not rounded to the nearest 15. And again, I'll be getting into the reasons why for that. But travel time rounded to the nearest 15. The documentation time is the actual time it took you to write and document your note. Direct service time is the combination of the time you spent with the person and your documentation time, then rounded to the nearest 15. So again, I'll be going through that in more detail, but 13 minutes plus the amount of time that I spent with George, and then rounded to the nearest 15. Okay, so now I have everything that I need for the note to be completed. So I'm going to go ahead and save that note. All right, now keep in mind, I'm going to get this pop-up that I can sign it, but I do not sign that note until I get a message from the service facilitator telling me I can. So now when I go back, notice how that icon just switched. So it switched to an unsigned progress note. Okay, now let's go to the messages. I can see that I have an alert about a message that I haven't opened yet. So I'm going to go ahead and get in there. This is a new message I haven't opened yet, but let's go over this. So in your messages, you're going to have two different kinds of icons typically. So the orange one is about a note that is approved to sign. So you can see here that this note looks good, please sign. So this is that note about delivering the support for the person learning how to use public transportation. And I can actually click through and read through that note, and then I would be able to sign. Now, there's a way in Echo, which is listed in here, how to set up a PIN signature. So rather than signing directly, you can just type in a number. So you're going to be able to do that. I would type in the PIN, and then that would save the signature for me. And then after it's signed, I could archive it, meaning move it over into what is done, so I can keep my inbox as the only things that are outstanding. Now I can see that I also have a note that indicates that a correction is needed. So I see here that this service facilitator said there is a typo at the beginning of the 4th line. The wrong person's name is included. Please correct and resave. So I'm looking at this note here, and this is a non-bill note. I can tell from the NB right here. So this one says, George confirmed he would meet for our 3 p.m. appointment. When I talked to him by phone earlier this morning, he mentioned he was still finishing up the form, and we talked through some of the information she needed to include. I waited for 15 minutes at the courthouse, but he never showed up for the appointment. Stevie didn't answer my call or text during this time. Later, I spoke with the service facilitator who let me know George was admitted to the crisis bed today, and he will let the team members know when he's discharged. So I put accidentally Stevie in, and actually looks like I used the wrong pronoun. So I need to go ahead and correct that. So I can click on that correction, and that will take me to the note. So I'm going to change those, and then I'm going to resave. You can see that reverted back to the blue. And then you may want to go into that note and just reply. Done. Thanks. Okay. So now the service facilitator knows that I made that correction, but I still need to wait for that service facilitator to come back again and say, it's going to have an orange icon. It's going to say, go ahead and sign it. Okay. Now, feel free to pause the recording and go back and rewatch anything on that that might be helpful. There's a lot to understand and learn about ECHO, and it will take you a little while. So in these slides, this is really essentially the content that I just went over. So this is the sections on that first screen that have to be completed. And this is, you know, what sections have to be completed for a billable note. One of the things that I didn't mention, you may have noticed, there is a selection box, and the version that we were looking at, there was only the transition to community living. That's because I was in the Ashland program. So in the Bayfield program, there's also a monitored ready for provider signature box. What you need to know is these are not boxes that you will select. Only service facilitators are making these selections. If you are working in the Bayfield County program, the service facilitators still send a ECHO message indicating when you can sign the note to finalize it, but they also do an additional step, which is select this box if they've reviewed it. And it's just a tracking thing for them, but it may help you as well. The Ashland program does not use that box. So your notes in Ashland will not have that. Okay, and then just a reminder, after you write your notes, you save them, you do not sign them. You wait for a message from the service facilitator before you sign it. Okay, this is the process that I've just gone over. So basically, the service facilitator reviews the unsigned note, and you'll get an internal message from the service facilitator in ECHO. So you need to be checking ECHO, stating one of these things. So either review, please review the progress note and make these changes, like you saw that change that I made, or maybe everything is good on it, so you can go ahead and sign it. And again, you can do that just from within that message. Or sometimes if there are significant adjustments needed, like if you're new and just learning how to write notes, you know, the service facilitator might send you an ECHO message saying, hey, lots of corrections needed, see my email outside of ECHO for specifics, because maybe they're including like screenshots and a whole bunch of information. What you need to know is once you sign the note, that is locked. It cannot be changed. And that also means that the service facilitators can mark that note ready for billing. So that is, you know, what happens after your note is signed. Now, with that in mind, we have a very manual process for how notes are entered and finalized clearly. And mistakes happen. You're human, and maybe something slips through. So in the rare occasion that you signed a note, and then after the note was signed, you realized, oh no, I put the wrong person's name in it, or I put, my documentation time was wrong. You notice an error. It's possible that the note may be able to be opened for corrections, but can't be done all the time. So where we need to start with this and the process for this is, again, what happens after you sign your note is that is really when the note becomes part of the official medical record. And that is also when our CCS billing department knows that they can submit it to Medicaid for eventual Medicaid reimbursement to our CCS program. Once your note is signed, it also means that your agency can invoice us, the CCS program, for our reimbursement to you or your agency. Speaking of which, on that service detail page where you see all of the notes that were written, that is how you know if you are an independent provider, like what notes are finalized so that you can use those on your invoice that you send to us. Now, why you want to avoid reopening notes is for these reasons. First of all, not all notes can be reopened. If the CCS billing department has already submitted the note to Medicaid, then that means that changes can't be made. Why that's bad is because once those notes are submitted to Medicaid, if Medicaid reads through that note, which they do, they spot check, and we are subject to announced and unannounced audits of our documentation. So if through one of those audits, it's recognized that, like a mistake was made, the wrong person's name was put into, the note, that is out of compliance. And that means that Medicaid could try to recoup the money that they paid for that service. And in your agency or if you're an independent provider, in the contract that we have with providers, it actually specifies that if that happens, the provider or the agency is the one that's responsible for paying that money back. The other thing is that it's kind of sticky icky because unlocking finalized documentation actually increases the CCS program's likelihood of being selected for an audit because it looks fishy. Why are you making changes to a finalized medical record? So these are the reasons why we really do not want to reopen notes, and these are the reasons why we have service facilitators review 100% of the progress notes that come in. Now, once again, you are human. Service facilitators are human. Things are missed. So if it happens that a mistake is made and the note needs to be reopened, the process that you need to follow to do that is outlined in the progress note submission and review and correction policy, but also here are the clip notes. So basically, when you notice it, you would need to send an email, so notify in writing, to the service facilitator and the mental health professional immediately to notify. The service facilitator is going to be the one double checking internally if the note can even be reopened. If it hasn't been sent yet to Medicaid for reimbursement, they'll notify you of that. And then as soon as that happens, the service facilitator and our internal billing staff will open the note back up. That means that the icon associated with that note is going to change from the signed progress note back to the unsigned progress note. So it's going to revert. Once that happens, you should make those changes as soon as possible. And then the typical process is followed for how that note is finalized again. So you need to wait for the service facilitator to send you an echo message indicating you can go ahead and sign the note. Okay, go ahead and pause the recording and go back to review anything that might be helpful from that most recent section. Next, we're going to be getting into the specifics of how you actually document and divide and calculate your time with a whole bunch of examples. This is kind of convoluted, so I'm just going to warn you that the process that we use is not super intuitive. So my suggestion, I would highly emphasize and encourage you to be keeping resources like this training and other resources I'm going to show you on hand, and refer to those when you are starting to enter your notes. As a new provider, you should really be referencing those with all notes that you are putting in. All right, so to get started, how you actually calculate and document your time. So first of all, you saw the process of how to enter notes is you first complete the service detail page. This is all the specifics about, the service that you delivered. And on that page, you are asked for your duration time. The duration time is all of the time associated with that service. So that includes your direct service time, the time spent with the person, the time spent traveling to and from the appointment, and your time spent to document the service. Now, why that's confusing is because you have not even gotten to the pop-up page where you enter your note. And so basically, when you're on this page, you don't know your duration time yet because you don't know how long it will take you to write a note. Typically, most notes will take 15 minutes to write. So my suggestion is, when you get into this page, just do your best estimate of what your duration time is likely to be so that you can get to that pop-up where you're actually going to be typing in your note. Now, you saw that my process that I would suggest is that you first start typing in your content. And when you start typing your content, go ahead and start your internal stopwatch. Actually, the time spent documenting includes the time putting things into this screen. So really, you should start kind of calculating from there. So go ahead and write your note. Then, after you're done writing your note and putting in all the mileage and to and from and all of that, that's the first cell I would suggest entering in. And remember, this is the actual amount of time that it took you to write your note, not rounded to the nearest 15. Now, this is confusing because essentially you kind of document your time for documentation twice. You put it down here, but it's also wrapped into your direct service time. The reason for that is because the documentation time cell is something that we use for our records that is specific to our kind of accounting and internal records. The yellow ones that you're seeing on here is actually what is forwarded on to MA. So that's the reason, but it doesn't make it easy to remember. So documentation time is listed here in actual time. And then your direct service time is the time spent documenting, so 13 minutes, plus the time spent working with the person individually. And in your head, you are adding that up, and then you are rounding that to the nearest 15 to get your direct service time. Okay? So this includes two things in that section. All right? And then your travel time, as you saw me enter, this one is rounded to the nearest 15. You do need to put in the actual mileage that you travel, and like you saw, the to and from section. Now, in that note entry and monitoring process document, there is some information about how you should document your time if you, for instance, stack appointments. Like you traveled to this appointment, but then right after that appointment was done, you went to a different appointment. So there are specifics about how you need to show that. We also talked about how you are not going to be making these selections ever, that those are only for service facilitators. I would say that the most common reason for requesting to reopen notes is because the provider forgot that they have to include not only the time spent with the client, but also their documentation time inside of this amount. So keep in mind that this is two things, and you need to do that addition in your head manually and put the correct amount into here. If after you've submitted your note, you realize, oh shoot, I did not include the 13 minutes in this. That's an example of, you need to immediately go back and correct that or ask for that note to be reopened. Okay, why on earth do we do it in this way? The reasons for why our time is documented in this kind of convoluted way really comes from the requirements of our billing. So again, because we bill through Medicaid, these are the state's rules around that. So you can see they require time to be rounded to the nearest 15, and you switch to the next 15 after you've reached halfway. So this is a little cheat sheet, which is included in that note entry and monitoring process document that shows you like the amount of time and what that converts to the nearest 15. The state's rules around documentation time. So the reasons why we need your the specific amount of documentation, not rounded, is because of this. So essentially, that is a requirement so that when we have audits, they can see that documentation. But how the services are actually paid is based on rounded to the nearest 15. So that is why we separate it that way, because how you are paid and reimbursed is nearest 15, but the documentation that we need as the CCS program includes the specific amount of time. And then this is just language around, the travel time and the actual amount of distance traveled. Okay, I'm going to go through 4 examples that we're going to use kind of like word problems of how you would divide out your time. And then we'll get into the last section, which is how to document your training and the requirements that you need to move forward with starting to meet with people. All right, but to start here, we are going to go through this one. So the example of the service that you provided is you meet with George to work on your authorized support at the library. It took you 26 minutes to drive there and another 26 minutes to drive back, which totals 52 minutes. You and George spent 40 minutes together focused on your support. It takes you 18 minutes to write your note for this service. Okay, so how do you divide your time? Basically, when you go to write that note, first things first, for the duration time, you don't have that yet, just put in an estimate on that first service detail screen so that you can get to the page where you're actually writing your note. Then the first thing you do is enter in your documentation time. Remember, this is not rounded to the nearest 15, and it is not automatically added to the direct service time cell. You need to add it to the direct service time. So manually in your head, you would add 40 minutes spent working with George plus the 18 minutes spent writing your note. That's 58 minutes. So that means you need to round that to 60 for your direct service time. Your travel time is 52 minutes, but because that's not more than halfway to the nearest or the next 15, which would be 60, this is an example of when it rounds down to 45. Okay, and then basically you are adding that 45 plus 60 equals 105 minutes, which is your duration time. Now, a little note, the direct service time cell and the travel time cell will auto-calculate to correct your duration time on that service detail screen. But keep in mind, you have to have accurate numbers in there. If you forgot to add the 18 into this, it doesn't know what's in your head. So it will only add what's in this cell and what's in this cell to get your duration. Here's another one. You meet with Alex to work on your authorized support via telehealth appointment. You and Alex spent 63 minutes together, focus on your support. It takes you 11 minutes to write your note for this service. Okay, so how are we dividing this? First of all, when you go to start a new note, you just enter in an estimate of your duration time so you can get to the pop-up where you're entering your note. You type in your note, and your note takes you 11 minutes. So you are putting 11 minutes into the documentation cell. Then you are adding in your head 11 minutes of time spent writing your note plus 63 minutes of time working with Alex equals 74, and that rounds up to 75 minutes. So that is your direct service time. For travel time, your meeting was telehealth, so you would not have anything in the travel time cell. So this is an example of where your direct service time actually equals the same as your duration time. This is also an example of if you forgot to add in the 11 minutes to the time that you spent working, you might accidentally put 60 in here, instead of including that documentation time. If you do that, just know that there's no possible way that the service facilitator is going to be able to catch that, because that is information only you know. And that is an example of a time or the calculation that would have shorted you 15 minutes of pay if you are not including your note writing time combined with your time spent with the person in this cell. Okay, here's another example, and this is actually the example that I had written the note about that we looked at in Echo. So if you want to pause this and go back to that, that might be helpful for you. But let's go through it. So you meet with Stevie to work on your authorized support, which includes helping them become more comfortable with riding public transportation. It took you 10 minutes to drive to the bus stop where you agreed to meet and catch the bus together. You and Stevie spent 27 minutes together focused on your support, which included boarding the bus, reviewing the bus schedule while you were riding, and then getting off at the same stop where you originally boarded. After you finish with Stevie, you drive to meet with a different participant at the library in another town. It takes you 23 minutes from the bus stop to the library. Once you get back to your office, it takes you 6 minutes to write your note for the meeting with Stevie. Okay, so how do you do this? First of all, you just put in an estimate for your duration time once you open up Echo to get into the pop-up cell where you're actually typing in your note. Once you get done typing your note, the first thing you do is drop that into the documentation time cell, which again is not rounded. That's the actual amount of time it took you to write your note. Then you add the amount of time it took you to write your note to the amount of time that you spent with Stevie. This equals 33 minutes, but that rounds to the nearest 15, which is 30. So that is my direct service time. Now travel, this is a little tricky. So the travel that you incurred going to that next appointment actually is not relevant to Stevie. You traveled to that next appointment for that other person. So this is an example of information and time that is not documented on Stevie's note. So the only travel time that you would actually document on Stevie's note is the 10 minutes that it took you to drive maybe from your office to the bus stop where you met Stevie. The other thing to note here is that the time that you spent on the bus with Stevie is actually not considered travel time. That's considered your direct service time. You are working actively on your authorization with Stevie. So again, that's an example of like you have to be careful about how you divide out your travel versus direct service time. So for the travel time, it took you 10 minutes actually, but since that needs to be rounded, your travel time is 15. So what that means is 15 minutes of travel plus 30 minutes direct service, which is inclusive of your documentation time, equals 45 minutes duration. So that's the total amount that's being billed. Again, that's the example of one of those notes that I pulled up. Feel free to pause and go back and look at how I wrote the note about delivering that service. Last example. You meet with Gloria at your office to work on your authorized support, which includes submitting a digital form. Your meeting is cut short because Gloria gets an urgent call from her son who needs to be picked up. You spent 10 minutes together focused on filling out the form side by side and saved the progress made when the meeting needed to end. It takes you 4 minutes to write your note for this service. Okay, so how do we divide this? First of all, when you first get into Echo, you are just putting an estimate in for your duration so that you can get to the pop-up page where you're actually typing in your note. Then the first thing you do is type your note, and that gives you your documentation time. So you are putting in your actual documentation time of 4 minutes into that cell. Then you are adding that 4 minutes to the 10 minutes that you spent with Gloria. You're adding it up in your head, and you're rounding that to the nearest 15, which is actually 15 minutes. That totals your direct service time for this appointment. And again, your direct service time is inclusive of the time you spent with the person and also the time it took you to write the note. Again, you have no travel time for this note because Gloria came to you. So there's no travel time included. So this is another example of where your duration time is the same as your direct service time. Okay, go ahead and pause if you need to and go back to review anything that was covered in that last section if helpful. What we're going to go into next is the requirements for how you actually complete your initial and ongoing training and other requirements. So we'll go through basically how you capture the time spent on this training and anything else that's relevant. And this all relates and is dictated by the DHS 36 administrative code. So this is where what I'm going to be explaining comes from. Okay, first let's talk about your initial requirements. And you probably already know this because you are watching this training. So you probably got it from me already. But initial training needed. So the amount of training hours that you need to document, complete and document and show on your initial training log for our program is based on how much experience you have working with people with mental health and substance use. So if you are a new provider with 6 months or more of experience working with people in those demographics, then you need to demonstrate completion of 20 hours of training that are relevant to the administrative code. If you do not have 6 months or more of experience working with people, then you are going to need at least 40 hours. Now, another note on this is one of the things that I require, and that's required to validate the amount of experience you have, is a resume or an application. So if you are sending me an outdated resume that does not show an experience that you had where you accrued that time, then I'm not going to be able to validate. You might need the 20 versus 40. So just keep that in mind. Another thing to note is if you are a rehab support provider or somebody who is a peer specialist, there is a special notation in the description of your role in DHS 36 that notates you also need to demonstrate that you've completed 30 additional hours within the past 2 years, and that is on top of either the 20 or the 40. So if you are a rehab level provider or a peer support specialist, that means that the initial training log that you submit to me is going to reflect that you have completed either 50 or 70 hours of training. Now, something to note is that you are going to have to complete UW Green Bay online training, which counts toward either that 20 or the 40 hours. There are two options for this, but the kind of condensed option is really only available to providers that are licensed and or credentialed through DSPS. So if you are not a license level, like master's level provider probably, then you are going to need to complete the full UW Green Bay training. So that means if you're somebody who needs, for instance, 20 hours, 13 of those 20 hours is going to come from the UW Green Bay training. Your agency's relevant internal onboarding training can also count toward your 20 or 40, assuming that they're relevant to your role and they kind of relate back to what you're going to be doing in CCS. The timeline for completion of the initial 20 or 40 hours also is different based on the qualification level. So by policy, if you are a DSPS, Department of Safety and Professional Services through Wisconsin, licensed or certified provider. So those are like therapists are the most common. Then you can count trainings that you've completed within the past 2 years of your start date with our program. The reason for this exception is because licensed providers at that level have to complete continuing education credits for their license every 2 years. So, and they also have a level of experience that is relevant to what CCS does. So if you are not a DSPS licensed or certified provider, then you must complete your 20 or 40 hours within 3 months of your start date in our CCS program. Something of note here is peer specialists are certified, but their certification is not facilitated through DSPS. So they would qualify under this requirement. There is an exception to this. So if you are a provider who has previously worked in another CCS program, regardless of how long ago that was, you may be able to transfer in much or some of the initial training that you did for that other program into ours. What you're able to transfer in is based on what documentation you have of completing that training. So reach out to me if you have questions about that. The documentation that you need to provide, or maybe, much of this could come from like your HR contacts at your agency, is listed here. And this is all part of the initial provider checkoff list that you probably would have gotten already. A lot of these are actually taken directly from that DHS 36 administrative code, but some of them are things that are relevant to our specific policies, procedures, things like that. Now, the ongoing provider requirements are what we're going to go through next. There are ongoing requirements for your continued training, and there are ongoing requirements for the supervision or clinical collaboration that you need to document completion of. And these are collected and reflected on an annual basis. So if you are just initially coming in and being credentialed through our program, your initial training requirements at 20 or 40 or 50 or 70 is going to more than meet your training requirements for this first year. So you would only have to worry about this, in the next calendar year. But the ongoing training requirements, so all providers in CCS, regardless of whether they are licensed or what their education level is, all providers need to have at least 8 hours of training per year relevant to their role. So this is something that is documented on, there's a log that we have, or maybe if the log that you keep for yourself or for your agency meets these requirements, you can use that. If you're somebody that's doing continuing education credits, assuming all of the necessary information is on those continuing education credits, I can also accept those. So typically, if you work at an agency, these might be something that your HR office could provide. Now, the ongoing supervision requirements are dictated by the level of qualification and the amount of direct service that you incur with CCS participants throughout the calendar year. So you can see these are divided into two different buckets here. So if you are a service provider at a bachelor's level or below, even with a license or without a license, or a doctoral or master's level clinician without a license, then you fall into this requirement. You must have at least 1 hour of supervision for every 1 to 30 hours of service that you incur with participants. So based on how much, face-to-face time that you have with participants, that dictates how much supervision you need at the end of the calendar year. And the next bucket is really the accredited and licensed doctoral and master's level practitioners. So if you are a therapist, you're going to fall into this category. So those providers need at least 1 hour of clinical collaboration, meaning like if you are staffing with other therapists, so clinical collaboration for every 1 to 120 service hours. So, keep that in mind, that difference, and then you're going to need to share that. So for this bucket of providers, your supervision needs to be delivered by someone who qualifies under roles 1 through 8. So essentially, a licensed therapist is who could provide your supervision hours. And then for this bucket or category of providers, you already have that qualification. So that's why clinical collaboration, not supervision, is appropriate. So you just need to collaborate with another person at that level to qualify as clinical collaboration. Another ongoing thing is the caregiver background checks and background information disclosure forms. So those are good for 4 years from the date that they were signed. So I kind of keep track of that, and I'll be reaching out to you if I need updated versions. All right, we're almost to the end here. So the last thing that I want to go over is all of what you need to finish completing that is specific to our CCS program. And these are the things that you are going to review, and then you are going to document on your initial training log that you submit to us. So you can see on this slide, there are many resources and policies that are specific to our programs that you need to open up and read through and review. This will take you some time, and all of the time associated with reviewing these policies and resources will be added together, and then that's going to be listed on your initial training log, which is going to count toward admin code 2. Okay, so all of the time that it takes you to read through the policies that are relevant to your role will go under that. There are also some other standalone things that go under their own line on your training log. So I'm going to flip over to our vendor and provider resources page, because this is where you're going to find a lot of this information. This is a page that I will continue to update, so it may look a little bit different by the time you're watching this training, but this is really where you're going to find resources that are relevant to you. So first thing, the staff directory. This is a directory of all of the internal Ashland and Bayfield County CCS staff. So these are the people that you are going to be working with, and we just thought it would be helpful to have kind of a name and the face associated with all of these people that might be on the other end of the communication that you are having. Next thing I want to show you is the referral. So the CCS referral page is here, and this is the regional referral. So all Ashland and Bayfield County referrals come through the same place and are processed through the same mode, which is information here. And then there is certainly a printable referral form, but you can also click on this online referral form, and that will walk you through a survey, basically, that's submitted for the referral. The note entry and monitoring process, again, where I found that when I very briefly showed that to you was on this page. And this document is something that I would imagine you are going to be actually using. More than just reviewing, you're going to be using it as you move forward and start, learning how to work in CCS and document all of your supports in CCS. There is more than just, how to enter your notes in here. There's also that process of how to unlock them. There is the information about how to set up your PIN signature for signing your notes, the information we covered about what echo messages are and aren't. There's information about non-bill notes and how it relates to the no-show policy. The process for addressing crisis situations, how you kind of determine that, which refers to a policy that I'll also refer you to. Writing notes when providing more than one authorized service, so how you kind of divide those. Notes when providing backup, how you divide travel across back-to-back appointments that you complete. And then also really helpful on here, the end of this resource is just a ton of real actual notes that have been redacted. And there are several that are similar notes or similar notes for the same type of service written by different people. So this is an example. Here's a note from a peer specialist for delivering peer support. Very concise, but we can see how it meets the rubric requirements. And here's another note from a different peer specialist that is clearly, much more detailed. These both meet the requirement. There's also notes in here about that just show really good examples of how to do things. There's a real note that was written about a crisis coordination support that was delivered. So you can see that. And there's also some non-bill notes in here. The progress note rubric is on this page. And I gave you the kind of highlights of this, but this is the actual rubric that has more than just what needs to be included. So there's also examples of like how you might meet this and what wouldn't actually meet the requirement. And these are divided by each section of the note. There's some common mistakes that we see. There's information about calculating your time. And then there is just an overview of, billable versus non-billable notes. The next one I want to show you is the progress note submission, review, and correction policy. So this is a policy we have on file. This one also includes the timeline for you submitting your notes. And there's information about that just walks through the process of how notes are submitted, corrected, reviewed, all of those things, the policy for if they need to be reopened, all of those. The travel policy, which is not going to be relevant to you if you are only providing supports via telehealth, so don't worry about reviewing it if that's the case. But if you will be traveling, you need to review this in detail. Notable things on here, we will not reimburse for more than 3 hours of travel for one appointment. So that will mean if you're traveling from really far away, it's advantageous to stack your appointments. And there is a difference noted here between what is acceptable and what is not acceptable in the Ashland versus Bayfield County programs about traveling with participants, which I briefly mentioned. The telehealth policy is right now, it's available in our master plan and policy document. And the rest of these are as well. But the telehealth policy really gives you the definition, it gives you some of those procedures I have briefly mentioned previously. And the telehealth provider agreement, there's an agency provider agreement and there's an individual provider agreement. Figure out which one makes sense for you. But you need to also sign this and submit it and get it back to me. The no-show policy. So this is, I mentioned I would go over this. Essentially what is outlined here is that if somebody no-shows for you, you need to communicate that. We would prefer that it's in a non-bill note, but you could also just communicate it via a phone call or an email to the service facilitator. The benefit of putting in a non-bill note is that it captures your non-billable time, which of course can be used in future rate setting. This no-show policy identifies that essentially our policy is our participants get 3 chances. After 3 chances of no-call, no-shows, that is when the service facilitator tries to intervene to figure out is there something else happening and to verify if the person still wants the support. If they do, and after all the requirements for re-engaging in that support have been, reviewed, then essentially they get 3 more attempts to re-engage. If they cannot, that is when the support would be ended. So keep in mind, if you do not document it, it is as if it never happened. So we cannot enforce ending a support because they're no-showing with you if you are not communicating that they are no-showing with you. If your agency or you as an independent provider have a no-show policy that differs from this, we are willing to work with you and utilize that if it's non-discriminatory. But we need to know that ahead of time. It needs to be shared with us before we would authorize supports with you because that's information that participants need to be aware of before they decide to add you to their plan. The policy for addressing a crisis is here. Now, this is really important to review. This outlines the 2 different kinds of crises that can happen. What is billable versus non-billable, which we touched on a little bit. How you coordinate services if there's an immediate crisis. And how you determine the level of it being a crisis or not. So that basically boils down to, we use the Columbia Suicide Severity Rating Scale. Also covered in here is if you are meeting with somebody and they consistently have like immediate needs related to like their basic needs not being secured, that's an example of something that maybe wouldn't rise to the level of an immediate crisis because it's an ongoing need. And that's an example of something that we will want to actually authorize a support for on their plan. So, this just goes through kind of if that seems to be the case, sort of how to address that, and then also how to communicate it. If you are an independent provider, then you are going to not only be delivering support, but you are going to need to send us an invoice at least every month for the supports that you delivered so that we can pay you. And the billing process is outlined here of how you do that. If you are not an independent provider or a supervisor at an agency, then this policy probably isn't going to be relevant to you. The ongoing supervision and training policies are going to be relevant. So I touched on much of this on one of those previous slides, but this just outlines, how much supervision and training is needed and, how that should be submitted, which essentially is via log to me. Here's that training policy. The ongoing training policy also references, if you are a new hire, that the initial training that you do, which you're doing right now, this actually might supersede that 8 hours that's needed within your first year of working in CCS. Okay. Beyond those, there are some other things that you still need to complete. So when you get to your training log, these things that are specific to our agency or our county are going to be things that are listed on this addendum. So these are the things I literally just went through with you. So the policies and procedures, after you're done reading through all of those things that I just opened up, you're going to document how much time you spent reading all of them. And you're going to list that here. There's also some others. So this brochure is something that you need to review. Oops. There we go. So this is something that every single participant gets in our program, and it outlines what their rights are. And this relates to you, because if you are providing service, you need to know about this being communicated and what to be aware of and what to avoid. The agency-specific job description, again, you need to sign your job description, and then you need to send it to me. So you can document 15 minutes of reviewing your job description on your training log. And the participant rights and grievance. So this is also gone through with all participants, I believe every 6 months. So you need to know that they have the ability to file a grievance if they feel like their rights have been violated. And please do read through this and then document your time for reading that. Now, this is also where you are going to document time for watching this recording that you are watching right now. And this recording, the content included in here is spanning across several different codes. So you are going to have to divide up the time. And by the time you see your initial training log, I may have the amount of time listed in there for you. Aside from that, the rest of your training, which there are plenty of other trainings that you need to do to complete that 20, 40, 50, or 70 hours. So they're going to be documented here, including if you are doing the full UW Green Bay training, those are in blue. And if you are doing the condensed version, those are in pink. So you do need to have at least 15 minutes of training in each one of these codes. So if you do not do, for instance, in code 10, you're going to need to complete maybe one of these trainings or something else that relates to this in order to meet your requirements. You cannot submit your log and not have training in, for instance, code 10. So you need to have at least 15 minutes in every section, and there are examples of trainings that already qualify and are approved in here, but you may also put in, if you've done other trainings, they can be included in here too. Okay, thanks so much for taking time to review this all. I know it's a lot of information. Please use this as a resource. So, pause and go back to anything that might be helpful for you and refer back to this training as you move forward. Thanks again, and thank you so much for the support that you will be providing to our participants.